Okay. Good afternoon, and welcome to our session on Lost in Translation, Diagnoses, Outcomes, and Equity. I'm Seth Joseph, Managing Director of Summit Health Advisors. I also am a contributing writer to Forbes.com, covering the intersection of healthcare, technology, and policy. So if anybody out there has a good story, please bring it up. Really excited about this panel, and I can't possibly do justice, so I'm going to ask my esteemed panelists to introduce themselves.
Hello. Great. The microphone works. Always want to do a mic check in this Zoom era. My name is MAIA HIGHTOWER. I am the Executive Vice President and Chief Digital Technology Officer at University of Chicago Medicine. I'm also the CEO and co-founder of Equality AI, which is a startup that provides machine learning tooling for responsible and ethical AI. And I'm a physician, so I'm an internist and continue to practice.
Thank you, MAIA and Seth. I am GEZZER ORTEGA. I am the lead faculty for research and innovation for equitable surgical care at the Center for Surgery and Public Health. I'm also an assistant professor of surgery in the Department of Surgery at Brigham and Women's Hospital, Harvard Medical School.
Thank you. Can everybody hear us very well, by the way? Do we need to turn it up? All right. Thank you. All right. Mic check, mic check. Does my mic sound nice? Check one, check two. There we go. All right. KIRSTEN Baker, CEO, co-founder of Jeenie. We are a virtual interpreting platform that connects caregivers and patients to an interpreter in about 12 and a half seconds in 300 languages to facilitate interpreting conversations. So on your smartphone, tablet, I come out of the language space. I've been in language and second language acquisition for a very long time, and then just running tech companies and finding ways of technology to solve everyday problems is an obsession of mine. So very proud to be here with this very wonderful panel.
Well, let's start off with the headline of our session, Lost in Translation. MAIA, I'd love to start off with you. What role does language or language barriers play in driving health equity?
Yes, so we know that patients who are limited English speakers have health equity inequities, and we're actually able to measure that. We're able to measure it through our patients where English is not their primary language, and they choose that within the EHR. And so, for example, at University of Utah, we were very intentful in measuring our population where English was of limited proficiency, and it was found that at least 15% of our patient population were limited English proficiency speakers, and we know as well that these patients had some of the greatest disparities in care, and we were able to measure that.
Yeah, and I'll add to that. I think when we think of language access and language barriers, think of language access as providing interpreter skills, providing interpreter resources as well as translated content, right, for our patients in the languages that they speak. And then we think of those barriers, we think of those instances where those things are missing, but also where there's a language discordance. That phenomena of where the patient and the provider don't speak the same language, and that it impacts the communication that they can have, on that one-on-one scale, right? And then when we think about the broader impact of that compounded on other health inequities within our system, right, it just tends to either can be a driver of inequity or a driver of equity when it is addressed.
We will often hear from our caregivers that, if I'm your patient, you're my caregiver. If you can't understand my symptoms, what's your likelihood of being able to diagnose me effectively or treat me effectively? It goes down significantly. And all the outcomes that come from that, I'm more likely to then be readmitted. My symptoms are more likely to recur. I'm more likely to be out of work again. The cost of the system is going to continue to go up to care for me. So there are a whole bunch of kind of repercussions of all of that. And obviously, we're most concerned with kind of patient health and the terrible outcomes that can come from that alone. But there are also system cost outcomes that are very costly. That's redundant, but a fact.
So studies suggest that only 12% of Americans are what we would characterize as health literate. I'm curious about the role of language related to this issue. How well understood is health literacy, and what role do language barriers play in addressing health literacy? GEZZER, I'm going to direct this one to you, and I know you're going to let me have it.
Yeah, thank you, Seth. And when we think of the scope of the problem, right? One of the first things that I always try to mention is that there are 26 million individuals in the United States that speak English less than very well or well. And that is what we consider the population of individuals with limited English proficiency, or LEP, which you may hear us say it while we're here on stage. And among those, and just to kind of give it a scope, right, that's 26, around 27 million individuals. There are about 29 million that have diabetes. And so that's how big of a problem this is, right, within our country. And so that's about a 1 in 10. And then you talk about digital, or you talk about health literacy, 1 in 12. And I always want to make a note of, like, health literacy and a language barrier or having language access are two separate concepts, right? One is about understanding the content that is provided for you in the healthcare space. The other is a language barrier or discordance within languages, right? And not everyone that has limited English proficiency has health literacy, right? Or has decreased health literacy, right? I have patients who are PhDs in other countries and come into our healthcare system and just they don't speak English and need to figure out how to navigate it. But I also have individuals who have low health literacy and a language barrier, right? And that gets compounded now. And so that then becomes even a bigger challenge. And so I think that there are areas where there is overlap, but there are also areas where there isn't, right?
Yeah, absolutely. And even to extend that thought process further, digital literacy. So when you think about that sort of perfect Venn diagram of LEP as well as health literacy and digital literacy, there are subpopulations that are disproportionately marginalized because of, say, that trifecta. And so being able to develop effective interventions that meet our patient populations where they are so important in order to ensure that those disparities in care are addressed and health equity is achieved.
KIRSTEN, I'm sorry. You mentioned earlier there being data around the role of language and addressing language barriers related to clinical outcomes, readmissions, et cetera. I wonder if you could expand upon that. Share with the audience any data around language and its importance to outcomes.
Well, I'm sitting on stage here with two people who have access to a whole lot of data. In fact, in full transparency, Dr. Ortega and I are, in a trial together. Actually, we're working in a trial right now where we are showing the impact of interpreting in the hands of caregivers and what it means for them to have immediate access to an interpreter where they can press a button and in, what we're saying is about 12 and a half seconds, have a live interpreter online, how that in fact impacts their interaction with patients, and then doing the same thing for patients. So I may turn it over to Dr. Ortega and Dr. Hightower to talk a little bit more about the data itself. But what we're seeing is, if 1 in 12 patients on average in the country show up as language discordant, that number in certain geographies in Texas and Arizona and New Mexico, that number can go up to 1 in 4. Right, there is a very large population that is showing up without that ability to understand and to be understood. And what we see, and we're just kind of talking about quick examples, is, again, the ability to then diagnose and treat effectively is a problem. That's a barrier. And, there are statistics out there, again, we'll hear more about those, but right now our understanding is about 55% of malpractice cases result from that miscommunication between caregivers and patients. That's not all language, but it's predominantly a driver there. There's another 12% of miscommunication between caregiver and caregiver. And so there's a tremendous amount of kind of, barrier there, to use the word. And that means that we're not treating everybody equally. It means that people are not experiencing. We saw, kind of during COVID, the fact that, the non-English speaking populations in this country were disproportionately affected because they weren't getting the information that they needed in their language. All of the symptom and the prevention information was all being delivered in English. And so we saw those rates kind of be extremely high. And Dr. Ortega, you've done some studying on that. Do you want to comment further?
Yes, absolutely. And the work that we've done has also demonstrated that for our non-English speaking patients, right, what we see is that there's also a decrease in understanding of their medical condition, a decreased understanding of their treatment plan, a decreased understanding of the medications, as well as just decreased adherence, right, to any plan and what we want, worse satisfaction scores with our patients that are non-English speaking, and then also increased readmission. We see delayed presentation for surgical care, and then also decreased or worsened outcomes for our non-English speaking patients. But then on the flip side, right, we also see when there is an interpreter present, right, a certified medical interpreter, when there are resources present, we see those rates go down, right? We see improvement that's significant across all those sectors I mentioned earlier.
I'll add just one other quick comment to that, Seth, which is, the other kind of element of this that sometimes gets missed when we're just looking at numbers is trust. Patients lack trust in their care providers, in the system, in their healthcare facilities if they don't feel like they're understanding or being understood, if they don't feel like they've been diagnosed appropriately, if they don't feel like they're getting better. And so having the presence of interpreting, having the ability to have those conversations, to know, what the kind of diagnosis is, to know how to be, there's a trust that's developed there. And we see that developing in also kind of making, attending appointments, attending follow-up appointments, the amount of no-show appointments kind of goes down because you're going to show up and be understood, let alone kind of the better healthcare outcomes that result from that.
So there are significant data to suggest that interpretation services do result or can result in better outcomes. We certainly know, based on what you've suggested, that lack of interpretation services and language barriers result in poorer outcomes. All of this sounds really important, and yet at the end of the day, is this just a nice to have for health systems? Because all we've heard about in 2022 and into 2023 are really no margin, no mission. If you don't have margin, you can't have mission. Is this a nice to have? And Kirsten, I'm going to direct this to you. Is there a business case to be made to the CFO? Do they understand that there is a sound business case, a real ROI to not just improving clinical outcomes through interpretation services, but an actual way to deliver bottom line value to them?
So when saving lives isn't enough, I get it, Seth. Yeah.
Sorry, I'm...
Yeah. It's a great question, and I will let two healthcare organizations here comment from their perspective as well. But what we see kind of resonating when we're talking to our clients is there are kind of two sides to this equation when we're talking to a CFO, and one is a cost-saving side for sure. The amount of time it takes for you to try to kind of work through a problem, a conversation, I should say, with a patient without interpreting is exponential. The kind of tool you have, though, for interpreting also is a critical component into how you save time. If we're dragging patients around and they're standing in hallways, trying to get on the phone and, over the phone interpreting has been shown to be so much less effective, or if we're having to run and find interpreters and, tablets and on wheels, there are lots of ways we can save that time. So time savings is critical. And what we know for caregivers is time at the bedside with patients, and efficient time at the bedside is really important. And there's tens of millions of dollars that we can calculate that show why that's at risk. The other side for the CFO case is a revenue generating one. So it's not just risk mitigation. It's not just malpractice mitigation and cost savings. But from a revenue generating side, if you can drive patient satisfaction in a population of patients who is inherently misunderstood, and when we haven't bothered to understand them, that is very significant. Now you're driving your HCAP scores, and not just because people are satisfied, but you understand why they're satisfied. You understand why a patient with LEP, limited English proficiency, is having a good experience, because patient surveys suggest it's not the care that patients care most about that drives satisfaction. It's the intangibles.
Yeah. And I would say that the most important first step is to measure. Because if you don't measure, then you can't actually calculate that ROI. And so it really starts with understanding your particular population and what percentage of your patients may be LEP or may have LEP, limited English proficiency. And that's actually a pretty straightforward calculation to do, but many health systems don't intentfully measure. But you can measure clearly in EPIC or in your EHR. Language preference is a field. Then you can calculate what percentage of your patients prefer a non-English language. And then from that, can calculate from the rest of the healthcare value equation, which is experience times quality over cost or revenue. And then from there, that is essentially the formula that my colleague outlined with the experience. You can take your HCAP scores, you can take your patient experience scores, and actually measure the disparity. And we know from Press Jeenie and from our HCAP scores that there is a disparity. There is a gap between the experience of our patients where English is a limited proficiency, and then same for every single quality metric. So all you have to do is take, whether it's your mammogram rates, your colonoscopy rates, your preventative health maintenance, or your mortality rates, right? And you can calculate for your health system what that costs, what that impact is, and then what the financial return would be if you gave appropriate care. And so whether you're in a value-based system or a fee-for-service system, if you've missed one kidney transplant, that's financial ROI. If you've missed a bunch of mammograms, there goes your value-based equation, your HCC capture, you name it. So it all starts, though, with measurement and measuring your patient population, making sure you're capturing that field. I would say, for an example, University of Utah has a very large refugee population, one of the largest refugee populations in the United States. And when we were reevaluating how we capture demographic data, we intentfully included a field for refugee populations because we knew they were extremely vulnerable, but we didn't have, at the time, the ability to measure the degree of vulnerability. And so, number one is just starting with your analysts and saying, hey, what's the magnitude of the opportunity? And then from there, it becomes a pretty straightforward ROI for your CMO, for your CFO, for your president, for your CEO, for your community.
Steph, and what I'll add to that is, one, I think that in order to have patient care, I think a lot of it happens in the small talk, right? And then having those conversations that are non-transactional allows you to really have the depth that you need to care for that patient on an individual level, which is really important, and where addressing a language barrier can move us from, can kind of move that needle with regards to health equity. But even more within our healthcare system, what we saw during the COVID pandemic was about a 30 to 40% increase in non-English speaking patients. And what we're seeing now is that about 60 to 80%, depending on the division of those individuals, are staying within our healthcare system, right? And so we have to meet that need, right? And so when we talk about that, how do we make the story to the CFOs, right? This is a new market, right? These are new patients that are coming in and entering our system, right, that need the care. And then on top of it, it is also a joint commission, right, requirement, right? Like every patient has to have a documented note if they're a non-English speaking patient, right? With an interpreter of some sort, right? And on top of it, starting January 1st, Joint Commission now has initiatives to drive health disparities, right? To improve upon them, right? And so hospitals are going to be put under, now requirements coming externally and not only internally, right? To make these improvements and do the things that, will push us towards equity.
Well, thank you. I think we've done a really nice job, one, educating me and the audience as well. We've talked about the nature of the problem of language barriers and the importance of interpretation services. We've talked about the clinical impact, and we've answered the question, I think, quite definitively around the fact that, yes, there is a business case to be made for providing solutions through services or technology. So would love to dive a little bit deeper into what factors health systems might want to take into consideration. GEZZER, I understand you recently went through this process. So what are the factors that were really important for you as you considered different solutions?
Yeah, I think when I think of solutions for interpreter services, I always want someone to be a high quality certified professional interpreter, right? First and foremost. After that, I need it readily available. I need it on demand. One of the common things that we hear from our healthcare professionals is that it takes too long. It's like 15, 20 minutes. I got to wait 30 minutes to get somebody, or if I'm using a phone solution, sometimes you can't hear well. The technology is not, where it needs to be. And then for many of our patients who have decreased hearing, they rely on reading lips, right? And so they want more video instead of just audio. And so those are some of the things that we've been hearing from our colleagues about, just what are the things that are going to help us but most important, that on demand, right? Like, I need to do this immediately. I needed access, right? When I think about high acuity situations that I could be in, right? I'm in a trauma setting. There's a patient that's coming in, and I need to communicate effectively immediately with that individual, right? It's so having resources and tools that can meet that need are going to be important.
MAIA, you're in a pretty distinct position as Chief Digital Transformation Officer. I'd love to hear your thoughts about this. What should other transformation officers, CIOs, Chief Digital Health Officers consider when they evaluate interpretation or language services?
Yeah, so I think when it comes to some of the digital solutions, really it's ensuring that the digital solution was designed to meet the patients where they are in their own digital journey. We do not. My own personal philosophy is that if a patient can send money to a small village in India on their smartphone, and we're not able to provide basic healthcare digital access, then that's on us, right? So clearly there are industries that are designing solutions that meet even the most basic of our patients that may have very low digital proficiency, but intuitive design that solves their pain points, where we have failed in that regard. And so simplification of our applications so that they're accessible to a broad audience, broader than just the middle of the road, but we're designing it so that it's accessible to everyone, is so important. And that really requires co-creation. Right? It means the people that we're creating these solutions for, that we're including them in the design process, that we have a wide variety of people and needs that we're addressing. And so I think that's definitely a top of mind when I think about some of these digital solutions. Right now, our current solutions that most health systems have are cumbersome. They don't work very well. They don't have the seamless experience that GEZZER mentioned. And for our providers, they actually cause a lot of headache and increased burnout and frustration as well. And so I think there's a lot of opportunity to continue to create that frictionless experience when it comes to our digital solutions.
Well, maybe that's a great segue. I'd love to hear, KIRSTEN, from you. You founded a company to provide interpretation services, a really novel approach. What did you see in the market that was out there that you looked at and said, this isn't scalable, or this isn't sufficient, this doesn't work well? Was it primarily a technological issue? Why did you go through the process of deciding something needs to be done about this? What was your motivation to found Jeenie?
Lots of caregivers who just said what GEZZER and MAIA just articulated, right? The not meeting people where they were, the very clunky technology solutions. So whether they're kind of awkward blue phones, in a facility, or just sort of over the phone, not video, or video, but only for this hour or this hour, I can't get the tablet, or I press a button, it tells me I'm going to connect in 30 seconds, but I connect to an operator or a call center, and now I'm waiting 5 minutes, which feels like 5 hours or an hour, for my interpreter. or my language needs are changing so drastically with migration patterns right now that to assume that Spanish English is all I need is absolutely incorrect. Quechua English, Quechua Spanish, which is a Mayan Guatemalan dialect, is one of the top needed languages now in the U.S. for medical interpreting. So we saw a lot of that. And when we were doing focus grouping, I come out of the language space. Most of our team has worked in a lot of, the companies out there. What we heard were speed first. So because it's in a lot of the folks that we're talking to are in surgery and trauma, but we need answers really quickly. We can't connect in 30 seconds to an operator and then wait. So our biggest, kind of goal there was making sure we developed a direct-to-interpreter technology. So you press a button, and in 12 and a half seconds, you're online with the interpreter. That was the first kind of key. The second one was quality. GEZZER says, quality. If I don't have a real, HIPAA-trained, medical-certified quality interpreter, then I don't even know if this is an effective conversation. It doesn't matter if they respond quickly. This may be, completely inaccurate. And so that meant doing things differently. That meant kind of instead of outsourcing to middle companies for interpreting, that we were going to go directly to the interpreters. We built a base of about 14,000. And we found a way that we didn't have to kind of pay the middle company in the middle, so we could pay them 2 to 5 times as much as the rest of the industry. Interpreter comp, equity on the interpreter side, on the provider side, just as important in making this work as equity on the patient side. And so being able to make sure that interpreters were being paid for their skills and valued for that has helped our quality go up consistently. And that's been big. And then the other kind of big piece that we heard, which was kind of a new demand, was mobility. People had a solution in for video remote interpreting. They had a solution for over the phone. They might have had an American Sign Language solution, but nothing for mobility. And the idea now of kind of healthcare being more and more decentralized meant caregivers need to go from the hospital to the clinic to the assisted living facility. People need to move around. And so that interpreter needs to go wherever you go. Quite frankly, it needs to be here. It takes somewhere between 5 and 30 minutes to get a iPad into a room or an in-person interpreter into a room. I am not kind of saying in-person interpreting isn't great. It is absolutely the number one preferred method by our deaf community. In general, patients don't prefer in-person interpreting because it feels more invasive than virtual, which is really interesting to us. But if you have it on a phone, if you BYOD, right, then you actually have people coming out of surgery. We've talked to surgeons who come out of surgery. I have 10 minutes to see a patient. I can run into a room not knowing if there's a language need or not. There is. I pick up my phone, I tap a button, I'm online with an interpreter, and I'm back in surgery, and I've handled a very significant conversation. So that was the goal, was to kind of meet both the caregivers where they were, and then to Maia's point, to meet patients where they were. So our whole goal is to not just have this available for caregivers on their device, but for a patient to be able to walk in, scan a code, and for a patient to be empowered to have interpreting on their device and control their own experience, and to feel like I don't have to worry if I'm going to have an interpreter at my session and whether I'll be understood or whether I understand.
Wonderful. Really well said. MAIA, GEZZER, any reactions to that vision?
I have nothing to add. Well articulated.
No, very well articulated, I agree. And I think for even some of the work that I do, I think really putting it in the hands of the patients has been key. Because I think that our surgeons, our healthcare professionals, it helps them to kind of have that readily available super fast. When we think about morning rounds, on average, a patient has about 60 different unique encounters in a hospital day. Very few of them are in a language concordant fashion, right? And so you could imagine as an English speaker, you can have all your conversations in a language you understand, but if you don't speak that language, like how many of those moments go missing because you don't have a tool or a resource? And so I think putting it directly into the hands of the patients makes this a lot more accessible. I know for like one of my residents, when I'm working, they're like, oh yeah, morning rounds, like this is great. I can go for a couple of minutes, speak to a patient, use it for a few seconds, and then continue on my day, right? And so I think it allows us to have a lot more language concordant encounters throughout the day. And as Kirsten alluded to, about only 10 to 20% of healthcare actually happens within the walls of our hospital, right? The vast majority is outside of our big nice, fancy academic medical centers, right? And so when they're in those spaces, when they're in CVS, Walgreens, Duane Reade, and the pharmacy, right, using this device to communicate with a pharmacist to get their medications, when they're at rehab and, physical therapy and all these other scenarios, right, like that include are part of healthcare, right, having something that allows them to have a conversation that goes very far in improving their health outcomes.
So, really love the vision that you all have just laid out. And I'd also like to acknowledge that barriers to communication are coming down thanks to technology, amazing technology improvements. So for the skeptic out there, MAIA, maybe I'll direct this to you first. Is it not enough to have Google Translate?
Oh, it's definitely not enough to have Google Translate. I think that's a pretty much given. This audience it seems very, pro translation services and know that acknowledge that Google Translate would not be sufficient. But I do think it's really important. Probably many of you probably don't obsess. I know there's one other person in this audience that obsesses about data quality and digital twins, and ensuring that when we're creating our digital representations of our patients, that is equitable across our patient populations. And so that's where, when it comes to the role of technology is only the derivative. Technology is a derivative of data, right? So technology is only going to be as good as the data that we're able to capture. And when we have disparities in the data quality of our more marginalized populations, then the derivatives of that, the technology that is developed from that, whether it's Google Translate, or for that matter, we know that for languages where there are small population sizes, Google Translate does horribly. So in that Mayan language, probably Google Translate fails miserably. But all small sample size and missed data types are going to have you're going to have poor quality of the technology that is derived from that. And so I think that's incredibly important that we realize that if we don't address the problem now, where the representation of our more vulnerable populations, whether it's language or race or ethnicity or gender, then we're going to widen disparities and not close them with technology.
Any additional thoughts?
I think the Chat GPTs of the world and the Google Translate, right? And I think it's definitely something that is going to be the future and help us, right, care for our patients. It's still not there. One of the things that I've worked with Google Translate, and we've had to, sometimes you're in a situation where, but it doesn't really get punctuation, it doesn't get grammar, right? And so when you ask a patient, are you having fever, chills, cough, and it gets translated, it just says fever, chills, coughs, right? It doesn't really understand that I'm really asking you, do you have a fever? Do you have chills? Do you have cough, right? And so the technology can't pick that up. And, one of my other favorite examples is even cold turkey. When a patient says, well, I'm going to quit smoking, I'm going to go cold turkey, it doesn't understand that that's the difference between, I ate a cold turkey sandwich and I have an upset stomach, right? And so they're both cold turkey, right? But it can't, that phrasing, right, comprehend that yet. So I think that it's working, right? It's something that needs to continue to learn and be adapted for us to be able to use it, but it's still not, the technology's still not there yet.
We've done we've had some wonderful studies done by the Center for Advanced Study of Language and other kind of language organizations that have looked at the impact, and we're excited about anything that wants to try to solve the language problem. So full stop. What we see in these kind of tools is that they are built for description and they are built for prediction. They're not built for understanding or opinions or being able to kind of respond with kind of new information being introduced. So if you're giving me symptoms and we're sitting there having a conversation and I'm supposed to come up with new information, that is not what these tools are designed to do. And so, I had a conversation, I don't know if I should say this out loud, but it was somebody with Google Translate in their R&D practice a while ago, and they said, we're here for transactions. We weren't built for dialogue. Dialogue is what you guys are supposed to do. And I think then when it comes to high-risk situations, medical being at the very top of that, you don't want to have that risk. And, when we see a lot of the studies out right now, even showing kind of like, oh, better accuracy, as GEZZER says, yes, there's better accuracy coming. But when you look at two-way conversations, English to Spanish, you might be able to get to a 68, 84, kind of score rate if there's, all kinds of variables being controlled for and not medical terminology, not people using fillers in their sentence or partially Spanish, partially English terminology. When you go Spanish-English, that drops to 38. When you go Mandarin-English, from English-Mandarin, that goes way down into the teens in terms of, so we're not ready for two-way conversations there. But I do think that there's an opportunity in the future to hopefully kind of like have a hybrid approach that will just help leverage interpreting in general.
Well, I think the importance of understanding language discordance and the importance of interpreters is becoming increasingly well accepted. But perhaps there are a few folks in the audience who are thinking, okay, I've been convinced this is really, I want to do something about this at my health system. If somebody wants to do something at their health system, they want to start off by raising awareness. What are the steps that they should take, do you think? Any counsel for folks out there?
Yeah, and I think I already started with measuring the magnitude of the problem, right, for your individual health system. And that's when you measure and make visible what we often don't make visible, then it begins the argument for why we should invest in a particular area. And then make sure that it aligns with your organization's strategic objectives. Because we know healthcare is broken, there's a bazillion problems, and if we tried to solve every single problem, that we would be incredibly overwhelmed and paralyzed. But aligning, your interest and the magnitude of the problem to the strategic priorities of your C-suite and the strategic priorities of the organization are going to be really important, because otherwise it doesn't get above the bar of the prioritization process. So those would be the two things: measure and then make sure that it aligns strategically. And there's ways that you can align it with your health equity goals. Often health equity is a strategic priority with your quality department, and so making sure you have those allies that can speak that language of, okay, this is a health equity problem, this is a quality problem. I now understand the magnitude, and I also understand the opportunity when it comes to revenue generation.
Yeah. And I would add, just go a little bit deeper into that measurement, not only measuring the patients, the languages of the patients that you speak, but also the communities that you serve. Because sometimes those may not be the individuals that are entering your healthcare system, but also your workforce, right? What is the linguistic diversity of your workforce? And even putting that out there on their web pages, right? So-and-so, Dr. XYZ speaks this language, right? That's an opportunity for more patients to come in and see that individual because of their multilingual diversity that they have. And then I think even more to that, getting more and more staff as qualified bilingual staffers, right? I think that's really important, because what we notice is that when we do that, our healthcare professionals will sit there and say, you know what, maybe the 3-week Spanish course I did is not enough for me to really communicate and, complex medical terminology to this patient, and I should rely on an interpreter or a certified medical interpreter and not, my own basic skills, right? And so I think it's important to measure, but also make sure that people are qualified bilingual staff within your institutions, and those are easy things, low-hanging fruit to do.
And to GEZZER's point, a lot of what we hear from bilingual staff are, I actually have a job. I actually have a role that I'm doing every day. And if I'm being pulled across, the hospital, the clinic, wherever I am to help do interpretation, I can't do my job. And so, that gets very tricky. And so having bilingual staff, I think, combined with solutions that are real, solutions that are available to people. We are hearing more and more about the idea of kind of BYOD, bring your own device. And I think hospital institutions, organizations, clinics, FQHCs that we see now are really kind of like pushing that, getting away from tablets in places and computers in places, because there was a recent study. I don't know if this is appropriate, language for this session, but that'll make it more provocative. So there's a recent study where they swabbed a whole bunch of iPads, across the country in healthcare, and they were looking at sort of, how clean are they, and the number one residue found on these iPads was human fecal matter. And, hospital systems are like, why do we want to deal with this? Why do we want to deal with charging? I mean, we're on tablets. So I'm saying, like, this is not even kind of me advocating for no tablets, but it is suggesting that the idea of making this available to everyone means making it available on devices that anyone can access. And, that gets back to some of Maia's points around digital literacy as well. But I think that that's really critical, and there's an investment that has to be made to do that. And if you don't have the, kind of components that MAIA and GEZZER just, reiterated or communicated from an institutional level, from a hierarchy and leadership and mission level, that's going to be very difficult. But start just by getting it on a device. Yeah.
So the Health Foundation recently published its Tequity survey results, and kudos to Health and ViVE for promoting Tequity and health equity as an important topic to be considered at this conference. One of the ideas of Tequity is the intentional design of technology solutions to address issues of equity. KIRSTEN, my goodness. Wow, it's embarrassing. KIRSTEN, I know. I have a friend, KIRSTEN. KIRSTEN, can you talk about how you thought about designing Jeenie in a way that addresses Tequity? And specifically, you and I have talked a little bit about the interpreter side as well. So I'd love to hear your thoughts from the audience and maybe some suggestions out there for others who are designing solutions.
Well, I think two points to that, and then I would love to hear from my colleagues here. The main kind of consideration for us was that for interpreting to actually legitimately be accessible to anyone, this couldn't just be a solution that was only available to caregivers. This also meant that we had to have kind of a consumer-facing solution. So we think about our solution not as B2B, but as B2B, we say C squared. It's the caregiver and the patient who can access this. So you all could open up your, smartphones, download the app, and you're off to Italy tomorrow. You want to speak Italian, you can use, you can access this, and we wanted that, but we wanted it also available in healthcare with all of the kind of rigor of HIPAA-trained, medically certified interpreters that were necessary. The other thing that we were considering was the number of languages and accessibility. We looked at most of the solutions that we've worked for, and there were 20 languages that were available between 8 a.m. and 8 p.m. if you wanted video, and we know how important video is. And we thought that just wasn't kind of sufficient, especially with the diverse growing number of languages and activity in languages. So putting more languages on board and considering dialects. If you go in and you look up Arabic for us, we have multiple Arabic dialects. We also consider that, we know that not all languages are, have written form. So we wanted to very specifically be looking at those languages that didn't have written form, but that are only verbal. And so when we're looking at the southern border right now and all that activity, coming over the southern border, those kind of languages demanded more attention that nobody was given to them, rare and indigenous languages. So I guess diversity in, sort of the modality of usage, diversity in, the languages themselves, and the diversity in kind of who could access the services was really important to us.
Yeah. As a user of Jeenie, what I will say is that it is the 24/7 availability is key. Like, I really never understood why interpreter services had like hours, right? The hospital's 24/7. Why aren't these services 24/7? Like, my non-English speaking patient may still have a question at 3 a.m. just like they do at 3 p.m. in the afternoon. So that was one of the aspects that was really important, was just 24/7 access to an interpreter, and even more just the quickness of it, right? In our traditional sense, what happens is someone's coming in. I'll give you an example. There's a patient coming into a trauma bay. The blood pressure's a little bit here and there. Heart rate's going up. You need to speak to them in their language. You have to pick up this phone, put in this code, put in the MRN, put in all this data, put in my number until I get to the operator, and then the operator's like, what language do you want? Okay, well, I need this language, and okay, finally I get an interpreter, right? Meanwhile, this patient's blood pressure's all over the place, and you're trying to figure out how to do this all at the same time, and your own heart rate's going up, right? And so I think the ease of it, right, having something where it's just like one click, two click, not only for the healthcare professional and us on this side, but even for the patients, I think was really easy, right? It's just like open the app, it's right there, you click on it, right? It's not, doesn't require too many, as I think Maya and I were saying, and there was a couple of sessions, right? Like the best apps are those that don't have instructions, right? Like you just pick it up and you start using it.
Yeah, specifically to your question about Tequity and designing solutions that meet patients where they are. I think one big challenge I think for healthcare systems, provider organizations, is that this is a capability we haven't developed. How do we develop this capability broadly and to learn from, say, the consumer space where it has been developed to a point where user stories and really understanding the pain points of diverse users drives development. And that's just something that healthcare provider organizations haven't intentionally developed. I mean, we do have community groups that participate, but we don't empower them to help us co-design and develop products. And I think that's an opportunity for healthcare to learn from the consumer space on how to develop better experiences, digital experiences and experiences in general, which, as you all know, we're not very good at. I'm sure you've had plenty of friction when you see your doctor or you see your provider. And I wish I could say that it's going to be frictionless in the foreseeable future, but these are capabilities we still have yet to perfect and are very low on the maturation scale.
Well, we've covered a wide range of topics here related to language, interpretation, equity. Any closing thoughts? I know we're over time, so we are going to be closing up here, but any closing thoughts, any things that we didn't cover that you want to make sure the audience walks away with?
I mean, I would just still say measure. Make sure to measure it, because if you can't measure it, then if you don't measure it, then it's really hard to make the case. And I think that's one of the biggest challenges with health equity or disparities in general is often we speak from the heart, we speak from a moral place, but often we fail to make that connection between the opportunity, the metric, the disparity, and then being able to operationalize that into a strategy and plan that the whole care team, the whole executive team can embrace.
I will add that there are so many problems within our healthcare system, and this is one in where we have technology and solutions that work and that we can implement today. And so it's one of the things that I always just encourage us to whatever solution it is out there within your healthcare system, implement it and use it, right? Because it can have a big impact on the patients you're caring for in their communities.
Yes to all of that. And finally, I would say that, we're here talking about, health equity. And the drivers of health inequity are very deep-rooted and very systemic, and they're not going anywhere for a while. But there is one thing we can do today, which is affect language as a barrier and as one of the drivers of health inequity. And so you can actually affect that today. It's not a nice to have. This is legitimately a way for you to mitigate real risk to your providers, to patients. And this is a way to drive more efficiency in your system. This is a way to actually generate, revenue. I'm making the business case because when saving lives isn't enough, we find that that is also a very compelling, way to think about this. That patient satisfaction, again, as we've seen the studies, patients who are showing up and talking about their satisfaction scores, it's not the care itself that drives their satisfaction. It's all those intangibles being made to show up and feel like, wow, you have an interpreter available to me, or I got to scan a code, I have interpreting on my own phone, I can guide my own experience. You thought enough about me and about where I'm coming from and my language barrier to do that for me, and it changes my whole experience here. And so to me, it's just a fundamental part of us, kind of being human in the way we're delivering our care.
Very well said and wrapped up. Thank you, Maya, GEZZER, KIRSTEN. Would welcome everybody here in joining me and thanking our outstanding panelists.